Hey everyone, let's jump right into this high-yield explainer on acute kidney injury, or AKI. You know, if you're prepping for your university-level exams or just getting ready to step onto the wards, you absolutely need a structured, clinical framework to really master renal pathophysiology. As an educator and nephrologist, I can tell you firsthand how crucial this is. So today, we're going to build exactly that framework together. To actually diagnose our patients effectively, we're going to use the classic anatomical triad approach. We'll just step right through defining AKI, then look at pre-renal perfusion, intrinsic parenchymal damage, post-renal obstruction, clinical diagnostics, and finally, evidence-based treatment. All right, Section 1, defining acute kidney injury and the Katie-Geigo criteria. Just keep in mind right from the start, this is a clinical syndrome, not just a structural one. Now pay close attention because this is a heavily tested concept. AKI is clinically defined by a sudden deterioration in renal function, which leads to the retention of nitrogenous wastes. Looking at the KDIGO criteria, you're specifically watching for an abrupt increase in serum creatinine of at least 0.3 milligrams per deciliter within a 48-hour window, or, alternatively, a drop in urine output below 0.5 milliliters per kilo per hour for at least 6 hours. Recognizing these early stage 1 thresholds, that is absolutely crucial for rapid intervention. Moving on to Section 2, pre-renal AKI, the perfusion problem. This is exactly what it sounds like. It happens before blood even reaches the kidney. So pre-renal azotemia is fundamentally a perfusion issue. The kidney tissue itself, initially, it's totally undamaged. The precipitating event is systemic. Think profound hypovolemia from a major hemorrhage, decreased cardiac output from heart failure, or a disruption in renal autoregulation. And hey, notice the common medications here. Drugs like NSAIDs actually prevent the necessary afferent vasodilation, while ACE inhibitors prevent efferent vasoconstriction. Either way, they drop that critical intraglomerular hydrostatic pressure, which leads to an immediate, steep fall in your glomerular filtration rate. Section 3. Intrinsic AKI and parenchymal damage. Now, if that pre-renal state we just talked about is really profound or prolonged, or if there's a direct insult, the structural injury manifests directly within the kidney itself. What's really helpful here is that we can systematically categorize intrinsic injury by its precise histological site. When you're looking at an intrinsic AKI, you should be asking yourself, is the damage in the vasculature, like you'd see with thrombotic microangiopathy? Is it an inflammatory hit to the glomerulus, causing glomerulonephritis? Maybe an allergic reaction in the interstitium? Or, and this is the most common, is it happening right there in the highly metabolically active and very susceptible tubules? That brings us to a crucial point. Acute tubular necrosis, or ATN, is by far the most common intrinsic cause you're going to see on the wards. It's generally triggered by two main mechanisms. First up is profound ischemia, often from sepsis or post-operative hypotension. The second mechanism is direct toxic hits. These can be exogenous, things from the outside, like iodinated contrast dye or aminoglycoside antibiotics, or they can be endogenous, like massive loads of myoglobin getting released into the blood during a severe muscle crush injury in rhabdomyolysis. Now, you absolutely must know the natural history of ATN for your university exams. It evolves in 3 very distinct phases. It kicks off with an oliguric initiation phase that lasts roughly 10 to 14 days, and this causes dangerous fluid overload and literally life-threatening hyperkalemia. Then it progresses through a maintenance phase of sustained uremia. Eventually, if all goes well, patients reach a diuretic recovery phase. Now, here, they can lose up to 3 liters of fluid a day. Why? Because those regenerating tubules just haven't recovered their concentrating capacity yet. So during this phase, rapid potassium loss becomes your brand new major clinical threat, leading to severe hypokalemia. Let's zoom in and see how this actually builds on a cellular level. Decreased oxygen delivery directly causes cytoskeletal breakdown right there in the tubular cells. As these dying cells slough off, they form this necrotic debris that physically clogs up the tubules. This blockage spikes the intratubular pressure, which actually causes the glomerular filtrate to leak right back across the denuded epithelium and into the bloodstream. It's just a brutal, vicious cycle of microvascular and tubular failure. Okay, Section 4, post-renal AKI and urinary tract obstruction. Think of this as plumbing blockages located anywhere after the kidney.
The pathophysiology here involves an abrupt increase in intratubular pressures that transmit all the way back up to the glomerulus, completely halting filtration. But here is a massive clinical pearl for you. Unless a patient only has one functioning kidney, a post-renal obstruction actually has to be bilateral to cause any significant rise in serum creatinine. So think of a massively enlarged prostate blocking the bladder outlet, or maybe a kinked Foley catheter. A single kidney stone in just one ureter generally isn't going to cause systemic AKI as long as that other kidney is perfectly healthy.
Section 5, Clinical Diagnostics and Labs. Let's dive into differentiating the triad using our lab results, because honestly, this is incredibly high yield for both your exams and your actual clinical rotations. So here is your classic diagnostic comparison. In pre-renal AKI, the kidney is hypoperfused, but structurally it's totally intact, so it responds exactly as it should, by holding onto sodium and water to try and boost that blood volume. Because of that, you'll see BUN to creatinine ratio greater than 20, a highly concentrated urine osmolality well above 500, and a fractional excretion of sodium, or FeNA, of less than 1%. On the flip side, in intrinsic ATN, those tubular cells are effectively dead. They can't reabsorb sodium, and they can't concentrate urine. Thus, the FeNA jumps to greater than 1%, and the urine is going to be dilute. Now, because we obviously can't always biopsy the kidney in the middle of an acute crisis, the urine sediment basically acts as our non-invasive liquid biopsy. You absolutely must memorize these associations. Normal or hyaline casts, that points straight to a pre-renal state. Muddy brown granular casts are the absolute hallmark of acute tubular necrosis. Eosinophils suggest an allergic interstitial nephritis, which is often drug-induced. And red blood cell casts, those are pathognomonic for glomerular damage, like you'd see in glomerulonephritis. Ultimately, all this laboratory data really just serves to confirm what your history and physical exams should already be suggesting. Looking for signs of volume depletion, evaluating the jugular venous pressure, assessing for sepsis, and taking a really meticulous history of recent medication changes or even just over-the-counter NSAID use, that is without a doubt your absolute best diagnostic tool. Reviewing the clinical features alongside these extensive laboratory profiles is exactly how you paint the complete picture of the patient, ruling out competing etiologies before you commit to a specific treatment pathway. All right, moving to our final section, Section 6, Evidence-based treatment strategies. Let's talk about managing the crisis with acute interventions and long-term strategies for these critically ill patients. Your treatment algorithm here is straightforward, but it is extremely time-sensitive. Step 1, rapidly optimize hemodynamics. If they're hypovolemic, give fluids. If they're in cardiogenic shock, you've got to fix the pump. Step 2, immediately discontinue any nephrotoxic agents. I'm talking ACE inhibitors, NSAIDs, aminoglycosides. Get rid of them. Step 3, treat the underlying cause, which usually means urgently relieving any post-renal urinary obstruction. And step 4, you need to prep for dialysis or renal replacement therapy if uremia, fluid overload, or electrolyte derangements become refractory to your medical management. And remember, while the kidney is attempting to heal, you have to proactively manage the life-threatening complications of renal failure. We're talking strict salt and water restriction or pushing high-dose loop diuretics for volume overload, just to prevent pulmonary edema. It also means aggressively addressing metabolic acidosis and treating hyperkalemia, using therapies like insulin, glucose, and potassium binders. Why? Because you absolutely have to stabilize that cardiac membrane and prevent fatal arrhythmias. Anticipating these derangements is just as crucial as treating the underlying cause itself. It is vital to understand that an AKI is not just some temporary bump in the road. Following that initial insult, the natural history can range anywhere from a full recovery back to baseline to a progressive downward slide into chronic kidney disease or even end-stage renal disease. Even patients who seem to recover clinically can undergo maladaptive repair. That means rapid, evidence-based intervention early on in the disease course is absolutely essential to preserving their long-term nephron mass. So, as you take this anatomical triad and apply it to your future patients, I want you to ask yourself this. When your hypotensive post-op patient with acute tubular necrosis finally survives their oliguric phase and enters that diuretic recovery phase, are you prepared to catch the rapid electrolyte shifts? Understanding these pathophysiological phases isn't just about passing your exams. It's literally what will allow you to anticipate complications and save your patients' lives on the wards. Thanks so much for joining me on this explainer, and keep